Yes, here we are. So welcome to you all. Welcome to the session on health for vulnerable people. And also a very warm welcome to our audience online. My name is Caroline Costongs and I'm the director of EuroHealthNet. And EuroHealthNet is a partnership for health equity and well-being, and we are based in Brussels. And I'm delighted to moderate this session with all of the excellent panelists we have here. I will introduce them briefly to you. So we have Professor Thomas Maribo. He is professor at the Aarhus University and research director at DEFACTUM in Central Denmark region. Then we have Christina Moderon. She is the head of the Unit for Policy and Strategy at DG Santé, European Commission. Welcome. Then we have Christine Sørensen, and she is the founder of the Global Health Literacy Academy. And I'm very happy also to have with us Freek Spinnewijn, and he is the chair of the Nobody Left Outside network and also director of FIANSA, which is a network of organizations that deal with homeless people. But before we move to the panelists, I would like to share with you some information about our work at EuroHealthNet, because last week we published a flagship report on social inequalities in health in the EU. And we launched this in the European Parliament at the Sant Committee, together with Professor Michael Marmot. And I wanted to quote what he said. He said that the promise of living in Europe and that it gets better every time is no longer there. So this promise is broken. And what have we done? And where did it go wrong? And the results of the report that we launched very much shows a concerning situation regarding health of people. And I wanted to use just a few minutes to share with you some of the results of our study. Because we looked at the data from the European Social Survey. Over 30,000 people were interviewed in 2014 and in 2024 with questions about their health, their mental health and social situation. And we found that 1/3 of the people reported less than good health, which is a huge number, no? And those with low education are twice as likely to report poor health than the higher educated. And if you look at inequalities in health between member states, we see a convergence of countries to meeting in the middle, rather than an upwards convergence for all countries. And if we look at inequalities within countries, between socioeconomic groups, then we see that inequalities are persistent and are widening, and in some countries where they are narrowing, it is leveling down. So the situation is not looking good. Then we looked at sort of what factors explain social inequalities in health. And the first factor, far and foremost, was people having financial difficulties. Second factor was people feeling not in control of their lives and lacking job control as well, which has a big impact on mental health inequalities. People also stressing problems with housing, and people stressing problems with their diets and access to healthy food. And obesity also was a strong predictor for explaining inequalities. So this confirms that we need to act on the root causes and on the social determinants of health. And in Europe, we have the European Pillar of Social Rights, which is actually a great tool to address the different social determinants of health. But we also need to have our own house in order, and we have to see, okay, what can we do as health people, and what can health systems do to address social vulnerabilities in health? And that is the topic of this session, because the European Pillar of Social Rights, at the moment, there is a Principle 16, and that is the right for everyone to have affordable and quality health care. And the Commission is going to deliver an action plan on the pillar and also on this Principle 16. And the purpose of the session together with you is to generate ideas and to see, okay, what should the Commission do to implement this right to affordable and quality healthcare for everyone, and what can be done. So, so let's first listen to our fantastic panelists, and I would like to start with Professor Thomas Maribo. And because in Denmark, they are also having a health systems reform, and they are creating categories of patients and dedicated specific packages of care. And that's sort of an interesting process. And Thomas, maybe you can say a little bit more about social vulnerability in health systems and how health systems need to deal with that. Thomas,
thank you, Caroline. And thank you all for being here today to our session, both here in Gastein and also online. Caroline, you mentioned Principle 16 in the European Pillar of Social Rights. Everyone has the right to affordable, good quality healthcare. This principle is about rights. That's not just about access, but also about ensuring that care is meaningful, effective, and accessible for all. Socially differentiated intervention may be a key approach for the EU to advance Principle 16 going forward. In the past few days, I've noticed how often the term person-centered care, person-centered treatment is used. But true person-centered care begins with the person, not with a diagnosis, not with the label of patient. We need to go from patient-centered to person-centered care. And to achieve that, we need to look beyond the medical problem and consider social support and everyday challenging as a very important indicator for health. This means also asking about people's social history. If we want person-centered care, we need more than the diagnosis. So what do we actually mean by socially differentiated intervention, and how could this approach be a part of the solution if we want to improve health in Europe? Socially differentiated interventions requires 3 steps. First, we need to identify the target group. Second, we need to stratify. In other words, understand the different levels of needs within that group. And third, we must tailor the intervention to match the needs and resources of those individuals. And to do this, we need to consider both individual and organizational health literacy. Organizational health literacy is about making it easier for people to navigate the system, understand information, and use it in daily life. It's about clear communication, removing barriers so that everyone has an equal chance to benefit from health interventions provided. We define the target group as persons in a socially vulnerable situation, recognizing that vulnerability is a dynamic situation and shaped by life circumstances. The target group here is people in a socially vulnerable situation, and that is someone who lacks sufficient resources to fully benefit from health interventions. Vulnerability is not an inherent trait. It's a dynamic situation shaped by changing circumstances such as health problems, life conditions, or lack of resources. As already mentioned, it can be temporary or it can be persistent, but it always reflects an interplay between personal resources, systemic factors, and life course challenges. It also reflects changing life conditions and structural constraints. One of the systemic challenges that we have is that people may technically have access, but they don't benefit equally because of barriers like resources, language, or health literacy. To capture this, we developed the Social Vulnerability Index. The index builds on and further develops the work of Jeannie Haggerty from Canada, and it's also informed by a systematic review of the literature on social vulnerability indices. If you want the literature review, you can just scan the QR code, but I think I may be in the way from that, so you might find it somewhere else. The index consists of 5 simple questions. You can also find the questions in the conference paper in the middle. The 5 questions are in the orange box here. The first question checks for language barriers. That's of course needed to see that persons can understand what we say and that we can discuss with them. The second and third questions are what we call, and also what Haggerty calls, flag questions. This is, do you have someone who can help you with daily tasks if you need it? And very important also, do you have someone to talk to if you have personal problems or need support? These flag questions are important and crucial for social support. So if you have a patient or a person sitting in front of you and they say maybe or no to these questions, this must raise a flag, and we as healthcare providers and as systems must provide information for targeting for them. The next question is about financial strain, and that is of course very important, and Caroline already mentioned that earlier. Here we do not ask about income itself, but whether the person struggles to make ends meet or to pay for medication and so on. And finally, we ask about education. In our review, we found 21 existing indices. Sadly, none were applied in daily clinical practice. None. They were all used retrospectively and mainly in epidemiological studies, and had a range of questions going from 5 questions, not exactly these, but some of them, to 42 questions. The most used item to identify vulnerability in the literature is education. We tested our 5 questions with healthcare providers, and they use them in their daily clinical practice. And after been using the questions here for about 100 patients with COPD, we had an interview with them. What really stood out to them was social support, especially whether a person has someone to talk to when facing personal problems or needs support when they are meeting the healthcare system. They saw this as the single most important indicator, and interestingly, education, which was the most used factor in the literature, education for them turned to be the question of least interest. But we asked them also about all 5 questions, were they relevant? And they say, yes, they are all relevant and they are all important. So we cannot take out even education, even they said it was not the ones of least interest. This tells us that we need to integrate these aspects more systematically in our needs assessment if we want to deliver true person-centered care. Sorry, I slipped the word there. True person-centered care. I believe that indices like the Social Vulnerability Index can be part of the solution. We need a new pathway, one that includes the identification and the stratification so that people in a vulnerable situation are recognized and interventions are tailored to their needs, resources, and health literacy. And here, organizational health literacy is essential. And I think Christine will return to that later, I guess. This approach strengthens fair access to outcome of healthcare. Social vulnerability is not limited to the marginalized groups. In Denmark, the marginalized groups is estimated to be 2 to 5%, depending on where you look, but something like that. But in fact, at least 1 in 4 people, 23, 24%, and maybe even more, are in a social vulnerable situation when they meet the healthcare system. So social vulnerability exists on a continuum ranging from entirely non-vulnerable to marginalized groups. And we have to at least look at the part of the continuum where persons are in a vulnerable situation. This is why we see the Social Vulnerability Index as a key part of the solution. It takes more than the diagnosis to ensure good health for all. We need to see the patients as persons in their social context to give good person-centered health interventions. Thank you.
Thanks a lot, Thomas, to highlighting the Social Vulnerability Index to us. And it would be good for you to, later on in our interactive session, to debate that. In the meantime, if you have some questions, and also for our colleagues online, we have the news desk, and we have Dr. Afsana Nejat. She is a Policy and Practice Officer at EuroHealthNet, at the news desk to monitor the questions online. And for those of you who will have hopefully some time after the panel. But I would now like to go to DG Santé and to see and to ask Christina what the approaches of DG Santé towards dealing with social vulnerability in health systems. And also regarding maybe that principle 16 of the pillar. And yes, the floor is yours.
Thank you very much, and thank you for the wonderful presentations before, because I think they fit well with, let's say, the current realities and challenges. Because, of course, health is not just a matter of hospital and medicines. We all, I think, agree on that. Health is also shaped by the conditions in which people are born, they live, they work, they age, we have seen, and I think it's very interesting, the study that you have presented, Caroline, because I think it's a reflection of the challenges in the last couple of years that we have seen in our economies after the pandemic, the energy crisis and the rising inflation. And I think, of course, I mean, we pick it up in its impacts in the data that we monitor when we look at inequalities and we look at questions of access. And of course, I mean, as DG Sante, we are really committed to the European Health Union, which also means building stronger and more equitable health systems that serve everyone, including the ones that are in socially vulnerable conditions. And I think from our point of view, there are, I would say, 3 major axes to look at this. First of all is, of course, how can we make inequalities visible and actionable? And I think that's because that's the first step where we have to start, is to look at how we can monitor the situation, how we can become aware of the challenges that vulnerable populations are faced with. And I think on the side of the Commission, we have the social scoreboard, we have also in our different, let's say, priority areas, for example, for cancer, we have done a lot of research into looking into where are the inequalities, what is really the situation for people. The same for people with disabilities. So this is the first step, is to study, to inquire, to survey, and to look so that we know exactly where the challenges are. We do monitor what is happening in different member states, also through the European semester. This is a very important tool for us. And because there we look at the situation, at the challenges, but also we have the opportunity to make recommendations. And as you know, it was also mentioned yesterday, there are 6 member states that received recommendation this year in the European semester process, and I would say a large majority of these recommendations, they refer to access and to increasing equity in the systems. Then, of course, the second element, and this is the European semester kind of touches both, is promote reforms. And how can we support, how can we help countries to move towards interventions that have the highest impact. And I think in this respect, just last Friday we published a study that we done jointly in DG Sante and with our joint research center that looks at the role of healthcare and in reducing inequalities, and tries to give member states tools to assess the distributional impact of healthcare reforms, to see which are the reforms that have the highest impact on reducing inequalities, how to design more equitable healthcare policies, and to provide this evidence-based support in decision-making when member states plan their interventions. And it was very interesting to hear your presentation, Thomas, with this concrete intervention, and to hear your experience in Denmark with trying to see how we can promote and concretely address in a very practical way, come closer to the populations, and that the system in a way goes towards vulnerable groups and doesn't wait for them to come and ask for help. Because I think this is also, I mean, very important and very much promoted or supported at European level to work locally, to have local partnerships, and to break these geographical, linguistic barriers and be able to reach out. Then the third element that is also very important for us is the financing, because of course this is key. On the side of DG Sante, of course, EU4Health has one of its specific objectives that focuses on enhancing access to healthcare. And we have had a range of actions supported in this respect, but also I think it's important to mention the Recovery and Resilience Facility, in which we have supported investments in healthcare accessibility through either digitalization, strengthening community services, and primary care reforms in member states. Of course, for us, the Principle 16 is key. We are now looking at the renewal or the update of the action plan, and it's very interesting for us. There was a public consultation that was opened, and we are looking into the input that we have received through that, and we're really happy to hear the input today that you have in this respect.
Excellent. Thanks a lot, Christina, for setting out the work that Santé already is doing, and also the avenues how Santé can further take up the issue of social inequality, thinking about the country-specific recommendations in the semester, and to have more disaggregated data in the social scoreboard, because it's still about averages, but it's great. There are opportunities there for sure, and we look also forward to hear what you think that DG Santé should include in the Principle 16 action plan on the right to health care. So let's now move to Christine. We talked about the right to health care, but also health is a human right. And what is the link between health literacy and health as a human right? And my second question is, Thomas talked about identifying social vulnerability in health systems. And then so what? What can health professionals do with that information? Two questions in one.
Thank you so much. We know that health is a human right. From some of our research, we see that health literacy is not a human right, but at least a human rights concern. And let me tell you why. We started looking at how do we actually describe people in vulnerable situation, or a vulnerable situation, as Thomas is saying. When you look into our science, we would describe them like this: hard to reach, hidden populations, seldom heard, underserved population, marginalized groups, vulnerable groups, disadvantages, communities, at-risk populations, non-engaged communities. And if we look at it from a justice perspective, we would call them individuals with lived experience of injustice, persons at risk of discrimination, justice-impacted individuals, persons in precarious situations, rights holders in vulnerable circumstances, socially excluded populations, equity-seeking groups, equity-deserving communities. So just to tell you, we have a tendency to categorize people, but actually people have faces. So that took me to the next steps, to look at what are the categories that we then look at in health literacy research. And that those groups that are at highest risk would be women and girls, children, refugees, internally displaced peoples, stateless persons, national minorities, indigenous peoples, migrant workers, persons with disabilities, older people, HIV positive, persons with or AIDS victims, Roma, Sinti travelers, lesbian, gay, transgender people, or those with low education who are poor, homeless, people with substance use disorders, unemployed, or are ill with high morbidity and multiple diseases. So I don't know about you, but I could at least take off several of all these categories. And it means that we're not talking about a small proportion, not at all. We're talking about the whole population. We can all find ourselves in vulnerable situations at time or with our family. So that's where we need health literacy, and it comes into the game. Health literacy is about being able to access, understand, appraise, and apply information to make sure you can manage health and navigate systems and take sound decisions. But not only for yourself. We also, we could have the best health literacy in the world, but if the system is not designed to listen to you, or if the system is not designed to accommodate your needs, we have a problem. We don't have a good match. Sometimes I feel like we're trying to put triangles into a square, these toy boxes where you could put in, there are lots of situations where we don't make a good fit. I learned a lot from Martha Nussbaum and her capability approach. So again, we can have a lot of competencies, but if our surroundings, our conditions are not having the good match, then we fail. And normally we would never look at the rights, because when things are going well, there is no need to look at rights. But when the social contract is broken, that's where we can look at those constitutions and the aspirations that we have. And so hopefully we can discuss this today, but let us remember that vulnerability has a face, and it could be any one of us in that place. Thank you so much.
Thanks a lot, Christine. And while I was listening to you, I was thinking, can we just assume that all socially vulnerable people are having low health literacy? Yes, I don't know.
Of course not. So that in one way we need to look at health literacy from a universal precaution perspective, so just assuming everyone has a challenge. On the other hand, we need to do what Thomas is arguing for, that we need special pathways and really take this personal approach, look at that situation, and this is where the organizational health literacy response come into the play, and the social mobility, as you mentioned.
Yes, thanks. Okay, let's now move to Freek. You are representing, let's say, people that are more marginalized. And what can you say about these groups and access and use of health systems? And in your view, what should the Commission be doing better? And particularly looking at DG Santé, what can they do? Floor is yours.
Okay, thank you very much, Caroline. Let me first say that, I work on the issue of homelessness for 25 years already, so I start understanding it. If you look for a connection between social and health, homelessness is a very good focus. Homelessness is a social problem, but it's also a health problem. So you don't have to doubt about that. We estimate that there is about 1.2 million people on any given day in a shelter or on the street in the European Union area. Most of them, virtually all of them, are in poor physical and or poor mental health. So we actually don't need a vulnerability index or social vulnerability index to know that. There is no risk that you're wasting money if you focus on homelessness from a health perspective. That's the first thing I want to say. I also wanted to congratulate you and EuroHealthNet with the report. It's a really interesting report. I also welcome the fact that housing is more and more recognized as a very important indicator, social determinant of health. Often forgotten. When you mention education, and it was also mentioned by Thomas, I think we have to be careful that we don't jump to conclusions about that. It's not because people are smarter that they're in better health. It's probably because people that have higher education are in a more comfortable living situation. So let's keep that in mind, because we heard from the Commissioner, the Health Commissioner earlier on, that equity and personal choice are very closely related. Not so sure about that. Can I say something about the Social Vulnerability Index? I welcome all that kind of work if it helps to make policies better, to target them better, to make the services better, etc. But I'm really quite concerned about these indexes when they're used for rationing purposes. And in a context where there is less and less public money, also in health, it can be used by policymakers to exclude certain groups that need support from that support. Even within the homeless population, there is this kind of vulnerability indexes to, for instance, target housing solutions better to those that are closest to death, in a way, while all the others also need housing support. So yes, for improving policies, but let's be careful and a bit worried maybe about it being used for rationing purposes. And you asked me, Caroline, what do we expect from the European Commission and DG Santé? Yeah, there's lots that we expect. But one thing is to have a slightly more sophisticated understanding of what vulnerability and social vulnerability is and what marginalization is. When I hear the word vulnerability or vulnerable groups, I have the impression that the whole population is actually mentioned. The groups that come back is women, children, young, old, people with disabilities, etc. But that kind of a superficial approach to social vulnerability de facto, I'm not saying purposely, but de facto exclude the most marginalized, like people that are homeless. If I look at the major health actions of DG Sante, the Beating Cancer Plan, the upcoming cardiovascular plan, the vaccination strategy, the mental health approach, the groups that I work with, the groups that I represent, homeless people, are consistently overlooked in these strategies. Consistently. I'm not saying purposely or intentionally, but in the facts they are overlooked. So let's have a slightly better understanding of who are the most marginalized and how to prioritize them. And the last thing I want to say is, when I said there is 1.2 million people that are homeless, most of them are in shelter beds. We think there is about 900,000 beds in shelter. These shelter beds are almost never used for health interventions. We know where these people are, we know they're sick, we know they're in bad health, and still we don't use it as a place for health interventions. We could do the same like in prison. Prison health is a thing, you know, it's something that exists. Why can we not have something like shelter health? I think it works, and maybe DG Sante can help us to do that.
Excellent. Thanks a lot, Freek, for your contribution. I think in a way it's two things, no? And on the one hand, we need to understand much better the marginalized communities and how their health is impacted and what can we do better. But also, we need to make policymakers understand that it's not only about health of vulnerable groups, it's actually a large group of people. It's the socioeconomic gradient. You know, every step you go down the socioeconomic gradient, your health gets worse. And there's large groups, as you were saying. And in our study also, it's 1 out of 3 people that report poor health. But this is a very complicated message, you know, socioeconomic gradient, that is. And then often policymakers talk about health of vulnerable people, and then the risk is that sort of marginalized as well in mainstream discussions. So it is complex, but important that both are mentioned. Right, we have just a few minutes now for some questions for clarification that you may have, and then I would like you to move into your interactive group discussions. So it's not yet for debate, and I would like to check with our news desk, Afsane, if there are any questions online already.
Yes, so thank you, Caroline. The input has very much echoed what was already discussed during the panel. One would be the emphasis, as Thomas and Freek put on having identification and stratification of data. And also mentioning that a lot of these social determinants of health that we're talking about are deeply linked with race and other systemic discriminations, and this is the kind of data that is not measured in a lot of EU member states. And also there was a mention of changing the tax system to be able to invest in addressing these social determinants of health.
Interesting, yes. Thanks for that. Just to look in the room, it's difficult. I see Vesna and a hand there. Yes, maybe first Vesna.
You know, thank you for this wonderful session, because it made my day. I was super frustrated in some other sessions because I didn't anymore understand where I am. Now I know where I am. I'm in Gastein, which is great. So something that bothers me, vulnerability index, fine. We are going to see which people are vulnerable and we have to address their needs. And then literacy, you know. Great, we have to make people literate, because otherwise they don't use appropriately the system. And it is about marginalized groups. It's not vulnerable, it's the marginalized groups that we should address better. How are we going to do this, Commission? How are we going to do this if we are saying that financing non-governmental organizations and networks that are there that could help us do it is illegal? How can we do it? We won't be able to do it because we have to invest in this part of society. They are there for us to help us to get people health literate, to serve those people that they will identify in public health or primary health care as vulnerable, to maybe offer something, support for those indicators. They are, you know, they are deprived of social interactions. Not the healthcare people can challenge this. We need people on the ground that will do all of this and mend all of this that is to be mended. And we cannot do without civil society, organized people. And that is our challenge today.
Yes, thanks a lot for that question on the civil society organizations on the ground as well. I have 2 questions and then we move to the panel to see who would want to respond.
Thank you so much. My name is Natalie and I'm the Youth Council member under the Ministry of Health of Ukraine. And my question would be, what the role of experience of non-EU member states can play a role in your strategies, in your work? Because I must say that war in Ukraine is such a vulnerable situation, and Ukraine adopts the finances and policy rapidly to help people with disabilities, which we have a huge number, unfortunately. So how you see the cooperation and your view on experience from non-EU member states, how they can help from their perspective to help shape strategies in EU. Thank you.
Thanks a lot. And then our third last question.
Yes, so I mean, I noted down some of the, let's say, quotes that were on the panel, and I don't know, when I look around here, there was the comment, for example, it could be any one of us, and I'm actually not quite sure. And then there was also a quote about the system is not designed to listen to you. So, I mean, maybe also in general, like a call to Gastein. I mean, when you have a panel, I mean, maybe include those voices also here. Especially, I mean, we talk about health literacy. Maybe there's also something needed like vulnerability literacy. So that maybe affects all of us. And since we don't have somebody like, for example, a homeless person here today with us, it would be lovely if one of you has recently interacted with marginalized people and could learn from their experience directly, that you could share one of these like personal stories, what bring you here to us from these people.
Of course, thanks. That is always a very good recommendation to include people from the communities themselves to which we talk about. Who would want to respond to the 3 questions? So one is on the engagement of civil society organizations, the second one on the cooperation with Ukraine and what can be done on this topic, and then the third point about inclusion of people in panels like this.
I would love to address the question of civic society. In my city, the shelters have been cut. There is no place now to get a free meal for people living on the streets or for other people in vulnerable situations. So other organizations are now stepping in, and I'm a member of Rotary International. And in my club, we were now cooking for the homeless people, so at least there is a meal with other organizations as well. We are not the only ones. So that is one thing. We also supported an organization helping people on the streets to move from the streets to a house. So they would get a house from the municipality, but what the leader there said, they do not get a home. And a house and a home is not the same. And we could probably draw the same analogy to healthcare organizations. You know, you would get your service, but if it's not provided with care, with empathy, with respect, with dignity, but you meet discrimination or you meet other types of barriers, then healthcare is not a home. It's just something you get, a product, or it feels alien. So let's learn from that, and I fully agree. We need to stick together. We need to make sure we get funding. If the funding is not there in public funding, we need to get foundations and other actors on board. Thank you.
I don't know whether Christina or Freek, would you want to respond? Yeah.
Okay. Just to say, of course, I mean, we are in difficult times, and let's say the competition for resources is very harsh, and this is a reality. Of course, we can see what we can do at personal level, and I was relating to what you're saying. So, you know, each and every one of us can see what they can do at personal level and how we can support keeping these topics high on the political agenda and raising awareness and making sure that these voices are heard.
Thomas?
Thank you for really good comments and questions. And I think what we need is a systems approach for us as healthcare providers also to be educated in more than the diagnosis. And I think it's, of course, always very important to include persons in a vulnerable situation. And you know, some of the persons that we talked to say, I'm not in a vulnerable situation. But then discuss with them, who do you discuss your healthcare situation with? Do you have somebody to talk to? And then they said, yes, the dog. So I mean, it could be all of us, and I think we just have to add this when we're interviewing persons meeting us in the healthcare system. We need to go beyond the diagnosis. And of course, there are persons in marginalized groups or very vulnerable or on that continuum in the end. And we need, for me, that's obvious. We need interventions that also are targeted to these groups. But some of the interventions that we applied in I work in cardiac rehabilitation, and in cardiac rehabilitation, some of the issues, mental issues, after you've had your cardiac incidents. And we found out that this person, that person, another person had this mental issues, and we thought, well, the intervention must be, we add this to whatever you get. And they say, no, I cannot take any more. I cannot get it in. So we had to tailor the intervention, and that was actually pull something away to make the intervention not the highway for them, but the tailored and saying, okay, you might not have this, you might not have this, because we'll go for this, and then add on if possible, but meet the person where he or she is.
Thanks a lot. It's particularly around multimorbidity, no? We will see more and more people with multiple chronic diseases, and how to shape the care package in such a way it is doable and feasible and understandable for vulnerable people. Very briefly, and then I would like to go to the exercise because time is flying. Yes, Freek.
Okay. Well, I don't want to speak on behalf of people with direct experience of homelessness. I'm very happy to cede my place next time for a person with direct experience of homelessness, and I can make some suggestions. But just to say, like, why am I mobilized and involved in all of this? And just to give you one statistic, I know statistics don't shock anymore, but I hope this one will shock you still. The average age of death of a person dying on the street as a homeless person is 50 years old. Less for women than for men. That statistic in itself is enough for me to be involved in this issue. And of course, civil society, yes, we're ready. As I told you, FEANSA represents organizations that manage 900,000 beds for homeless people. We're ready to work. But the context is not so favorable at the moment, you know. If you want to work with civil society, I don't think it's a smart thing to stop operating grants for European NGOs, you know? Mm-hmm. I don't want to ridiculize it, but like it starts there. And maybe very quickly on the continuum of vulnerability. I understand where that comes from, and it's probably logical, and it's partly the reflection of reality. But another part of the reality is that if you talk about vulnerable and marginalized populations, you have deserving and undeserving groups, also in the area of health. Mm-hmm. And I think we, as FEANSA, work on a group that is undeserving. It's very difficult to mobilize policymakers and health services on this kind of target group, because people don't say it publicly or explicitly, but they are considering people that are homeless less deserving than some of the other groups, like people with disabilities, older people, etc. And I think we should be aware of that.
Yes, indeed. Thanks, Freek. All right, so this session is about generating ideas for the action plan of the European Pillar of Social Rights, and then Principle 16, which is the right to quality and affordable health care for all. So the idea now is that you have 1 minute of reflection for yourself, what you think the European Commission, and particularly DG Santé, can do or should do, and what do you want to see in this action plan. The action plan is scheduled to come out, I think, by the end of this year, or no, beginning of next year, I think. So it's prime time now, and so I will give you 8 minutes. I think I had 1 to 10, but 8 minutes to first think about yourself and then form groups of 4 people. And with 4 people, you discuss what you think should be part of this action plan. And then we would like you to insert your suggestions in the Slido. So this is the Slido QR code. And then meanwhile, we will keep it open, so our panel members will look at what you are suggesting, and then we'll do 1 final round of our panelists at the end of the session. So the time starts now. So first think a bit about yourself. What would you want the Commission to do? Can we have the questions also of the Slido on the screen? Yes, so what measures can be taken to address social vulnerability generally, and specifically what can the EU do, knowing also the competency of health systems, etc. And then please discuss with your colleagues. All right. I suggest that we now wrap up this interactive part. I saw a wealth of input into the SharePoint. Please continue to do so. And also for our participants online, thanks a lot also for your input. And our panelists have been looking at what you are suggesting. And I would like to give the floor to all of the 4 panelists to respond to the various suggestions that you have been making. And I would like to start with Freek, if that's okay. Yeah.
Yes, you're the boss. Yes, so I'll just pick out 3 that I can easily relate to. There was quite a few people that said we need to work on a better link between social care and healthcare. Yes, obviously, I agree, that's the case. It's not so easy, though. If I look at my own sector, the homeless shelter sector, there is a general lack of expertise in that sector, professional expertise in the area of health. And because of that, there is also a tendency to underestimate the health dimension of homelessness. On the other hand, the people working in the health system, certainly the mainstream health system, are not necessarily aware of what homelessness is exactly about, and that might lead to complicated access, etc. So, to bring those 2 sectors closer together will require things like training and stuff like that. I think we shouldn't underestimate the complexity of doing that. But I totally agree that there is an urgent need to bring the 2 sectors closer together. Maybe to just say quickly an example of how we underuse the health system to prevent social emergencies. We know from research that before people become homeless, especially families, there is a spike in the use of health services, especially linked to the GP. So if we would use the mainstream health system, if you ask doctors and medical professionals, ask people generally about their housing situation, I think it could help to more effectively prevent homelessness, imminent homelessness, with all the costs that it brings also to the health system. So yes, health and social closer together, absolutely agree. Some people said we also have to integrate the commercial determinants of health when we speak about social vulnerability and all of that. I think we have to be careful that we don't make an artificial split between commercial and social determinants of health. If you take the example of housing, for instance, it is a social as well as a commercial determinant of health. Housing is increasingly financialized. It becomes an investment product with all the consequences on the affordability and the quality of housing. So it is an increasing commercial determinant of health as well as a social determinant of health. So instead of trying to keep them separate, I think some of them can be integrated into one. And then there was some people saying, yes, we have to identify best practices and mutual learning, etc. And as the director of a European organization that does some of that, I agree, of course. But we also have to be careful that we don't like stick or get stuck in this kind of piloting stuff, and then once the pilot is over, it stops, you know. Like some best practices are out there, we know they work, and it's time to scale them, bring them to scale. And I think the European Union can play a role in that. To just give you one very quick example, Housing First for very complex homeless cases, where you provide the housing, for instance, for people with addiction problems and mental health problems, and you don't oblige them to take social support to deal with their non-housing problems. You leave them the choice to deal with that or not. That's in short Housing First. It works very well. And now it's time to bring it to scale, rather than endlessly identify that interesting best practice. We know this by now. So,
thanks, Freek. Maybe also good to mention that the European Commission is working on the first ever European affordable housing plan. And I know you are very linked to that, and it is in all our interest to make sure that health and the link between housing and health is very well considered there, and also maybe nice to know how something is cooperating on that plan. Christine.
Yeah, thank you very much. So first of all, I want to make a disclaimer. I fully respect and love and are passionate about health and all the great work that our colleagues in the healthcare system and social systems are doing every day. I think we saw it also during COVID. We wouldn't have the results we have today if they did not step up on behalf of all of us. When this is said, we are nowhere near eradicating social inequality. Nowhere near. And the thing is, there is a myth that we have good welfare systems, good educational system, good healthcare systems, good social system. Yes, for most of us. But there is a system failure we still need to face. And that requires courage, because healthcare has also an ugly face. There is structural racism, structural discrimination that we need to face to lower and reduce the barriers for everyone. And the main message today is really leave no one behind. Whatever it takes, leave no one behind. So we have to leave that feeling of doing good and thinking we do good. I think we are in most occasions, but there are situations, vulnerable situations, where we are not. And we need to face it. And I think this is where we as health professionals in all capacities, health managers at all levels, we need to address every situation we see where the social contract is broken, where human rights are broken. And that takes courage. It takes courage to be a whistleblower. It takes courage to stand up, speak up, show up, also for those who do not have their voices heard. So I hope this is the pledge that we will take home today, and recognizing that we're facing triple burdens. If you're poor, if you have poor education and a poor health, you have also a risk of poor health literacy. So that compounded effect can also be, we are one of them, or they are one of us. We are all in the same boat. We are all connected. And this is where I think we have to make sure we leave no one behind. Thank you.
Super. Thanks a lot, Christine. Christina.
Thank you very much for the very insightful comments in the Slido. I think, of course, it's they all underline the complexity of the issue, of course, from our side, we are fully committed to support a health in all policy approach. And of course, we are, as much as our own limited resources allow, present in the different policies, housing, the anti-poverty strategy. Yes. There is a lot of work going on at European level, and we are doing our utmost to make sure that the health dimension is well reflected in these actions. Then, of course, I think there is also a realization also that there are certain things and certain challenges that have to be tackled at local level. And while we at European level are responsible to raise awareness and to keep certain topics on the agenda, vulnerability and a lot of the issues related to it have to be seen also in their specific cultural, local level and local dimension, because one size fits all does not work at European level. Each member state has their own specificities, has their own cultures and their own ways and certain things. And of course, we need to make sure that we have platforms in which we can share best practices and learn from each other, but then also see how all these actions, how they can fit with the local realities and cultures. And I think this is where, I mean, this is where the responsibility at member states and the local, regional and local level kicks in. And then of course, there are many connected issues. I see a lot mentioned, mental health issues and challenges, and this is as with housing or with other topics. These are recent topics in which we have felt the need, and we have tried to federate attention. Of course, it's not, I mean, with the limited resources that are available, there are no quick fixes, and there are no solutions that will solve these systemic issues. But at least, and I think the fact that we're having a discussion, that we are reflecting together, that each in the sector that you are focusing on are committed to bring this agenda forward. I think it is very encouraging for us to see and to experience, and I think this is a challenge that we will have to tackle and take forward, and do our best to be up to the task.
Thanks a lot, Christina. Thomas, yes, so you have the final word. What are your take from the various input from our colleagues in the room and online? And yes, floor is yours.
Thank you, and thank you for all the nice comments on the Slido. I'll just say that we will take all these comments back and we will wrap them up in a sort of report and discuss with EuroHealthNet, and of course also provide them to Christine and her team. So I have a long list of, I think, 10 things to say, and we have 1 minute left, so I won't go into that detail. I just think that the second session I attended here in Gastein, I think it was the second session, says we have an issue because we have a health system that's specialized, and persons meeting with multi-morbid or social problems. So that's really an issue that we need to tackle in order to create more equity. And then also from the session here earlier today, we need a shift from individual risk factors to systemic risk factors. And that is also, I think, what's very important. And then just one final comment from me was from one of the Slidos, and I think that's very important because we need a long-term strategy.
Yes, thank you. Indeed, and definitely a long-term strategy. I think, we will see more and more people with chronic diseases and multimorbidity. Our report says that social inequalities are widening, and I fear the trends will not become positive in the years to come. Health systems are struggling. There will be more and more fiscal constraints. So we have an issue that we will need to address on the short term, but also on the long term. And I would like to thank all of you for your input that we will use in our report and give feedback to the European Commission. And I think this was a really very great session. I also would like to thank all of the speakers for your insights and how to proceed on reducing inequalities, and also for our participants online. And Afsana, thank you to manage the news desk. And I would like to also thank Jacob, sitting very much at the back from DEFACTUM, for organizing this session together with us. So thanks to you all, and let's continue to all work for equity and reducing inequality together. Thank you.